Muchas gracias, Gloria. I would like to thank Roberto and Ismail Train. Today is a happy day for us from Bauru because today we are celebrating 56 years and more than 100,000 patients treated in this frame time. The comprehensive cleft care and the results of the treatment is the result of the efforts of this big team. And we, following the concepts of the American cleft, scan cleft, we decided 3 years ago to draw with Dr. Terumi and Dr. Melissa centrineo cleft. But different the scan cleft and American cleft, we evaluate different surgeons and not different centers. And in following these concepts, we evaluated facial appearance, facial growth, and speech results. We evaluated patients with unilateral cleft lip during 2 years, non-syndromic patients, and we follow this treatment protocol. Quickly, our protocol is probably the same of the majority here. We do the Millar or Fisher technique for lip repair, Skuggen-Macomb for the nasal wing, and palate in 2 stages. The anterior palate during the lip repair, and the second time in 1 year old, the total palate repair. For nasal label, according to the scan cleft, American cleft special, we evaluated the nasal label appearance considering nasal shape, nose alignment, vermilion border, and profile view, using these photos, these standard photos, following Asher-McDate criteria. And we evaluated 139 patients, 90 boys and almost 50 girls in this sample. That's an important point here because this evaluation happened when the child was almost 7 years old. And we are evaluating 9 different surgeons. For the nasal and facial appearance, we used this score, and we evaluated with 3 expertised cleft surgeons, considering 1 for excellent appearance and 5 for very poor appearance, and 2 to 3 a fair to good result. And you can take a look at this agreement of the examiners for this appearance. And that is our results for the nasal label appearance. The overall, the median of our results is something like 2.34. It's like fair to good result. We have a wide variation between the surgeons. We have one surgeon with the good results like 2.12 and another one with 2.50. And in some aspects of this evaluation, we have in some aspects the surgeons with 3, sometimes with 1.2. And it's a great variation between the surgeons. Our results ranged from 2.12 and 2.50, and okay, it's fair to good. It's the same of the American cleft study when 224 children were evaluated. Considering fistula rates, it's the same of the majority. Our patients shows the fistula between hard palate and the transition of the hard to soft palate in the most of the cases. And the overall fistula incidence was something like 20% for these patients. And in the 50% of these fistulas, we had the fistulas with less than 1 millimeter. And when we exclude these punctiform fistulas, we have 8.6% of the fistula in our service. That is interesting to evaluate this fistula per surgeon, because in this picture we can see the variation of the fistula in the surgery, in the proportion of the fistula and the surgery, and the surgery per surgeon, and that is the point. When we measure these results, especially for each surgeon, it's possible to solve or try to fix these problems to select the primary surgery just for the best surgeries, best results surgeons. We have to consider that the adequate palatal function for these patients was present in almost 80% of our patients, independent of the fistula. For the maxillary growth is the same. We used, Dr. Terumi used the Goslow index, and we found almost something like the Carlos Juliano showed, almost 50% of the patients with need to orthognathic surgery. And in the middle, in the yellow zone, almost 40% of our patients. It's the same for the speech outcomes. We evaluated 170 patients, the same sample, and the same protocol, and 14 speech pathologists evaluated these cases during 5 to 8 years old to 10 years old, using this Brazilian Cleft sentence, or this is the standard parameters to evaluate hypernasality, passive errors, active errors, and velopharyngeal function. And here we have the distribution of the different techniques, like von Langenbeck for the most of the cases, especially for the senior surgeons, and Summerled and the Braithwaite technique for these patients. And we identify the almost 20% of the velopharyngeal insufficiency in our patients. But we have to consider the difference between among the techniques. We have 11% of the velopharyngeal insufficiency using Summerled technique, and the other side, 25% using von Langenbeck modified technique. This, the same, the performance of the surgeon and the result of the velopharyngeal competence in this case. In conclusion, in Centrinho, following this sample and evaluation, we have nasolabial appearance like fair to good, considering Asher-McDade criteria. The overall fistula incidence was higher, 21%, and with this considering if you exclude punctiform fistulas, we have something like 8%. The maxillary growth and 25%, at least 25% of our patients are going to the orthognathic surgery, and the velopharyngeal insufficiency is like something 20%. Facing this, maybe two-stage palatoplasty could be a good medical protocol option. These results reflect the outcome of our team, and it's necessary, it's important to measure these results. Now we are starting to evaluate our bilateral cases to improve our service, our assistance to our patients. Thank you.